Welcome to this lecture on acute diarrhea. The definition of acute diarrhea is having greater than 3 stools per day which take the shape of their container for less than 2 weeks. Likely pathogens include viruses such as norovirus, rotavirus, adenovirus, and astrovirus, and some bacteria such as salmonella, campylobacter, shigella, certain E. coli, and Clostridium difficile. Protozoa cause acute diarrhea. These include Cryptosporidium, Giardia, Cyclospora, and Entamoeba. When seeing a patient with acute diarrhea, it's important to take a thorough history. This is to help you determine the etiology of the diarrhea as well as for public health reasons. So you should ask about exposure to food and illness among close contacts to see if this is part of a foodborne illness outbreak. You should also ask about recent travel, as foreign travel predisposes patients to certain pathogens. You should ask about HIV status and about the use of recent antibiotics. You should look for specific clinical features and ask whether there is blood or mucus in the stool, whether the patient has fever, is vomiting, or is dehydrated and even has hypotension. You should then ask yourself if the patient is sick enough to require hospitalization or has blood mixed with the stool. If the answer is no, then no antibiotics are indicated. You can prescribe oral rehydration and consider antidiarrheal agents such as loperamide. If symptoms persist for greater than 2 weeks, then this becomes chronic diarrhea and further investigations are required. If the patient is sick enough to require hospitalization or has blood mixed with the stool, you must resuscitate and rehydrate the patient. You should send stool for microscopy, culture, and sensitivity. Also for ovocysts and parasites if they're HIV positive, immunosuppressed, or have recent travel. Stool should be sent for C. difficile toxin if there's been recent antibiotic treatment. And in these cases, you should consider empiric therapy only if there's bloody diarrhea, fever greater than 38, or severe dehydration. If a stool sample has been sent, you must check the microscopy to see if leukocytes are present. If not, then this is a non-inflammatory diarrhea. No antibiotics are necessary. You should give symptomatic treatment and consider antidiarrheal agents, and if parasites were seen on the stool test, then these should be treated. If leukocytes are in the stool, then this is inflammatory diarrhea. You should treat the patient based on the stool culture and sensitivity results, and once again, if parasites are present, they should be treated. In terms of treatment, if you're giving empiric therapy for acute diarrhea in an unwell patient, then ciprofloxacin given orally is appropriate. If they have bloody diarrhea, then you should add metronidazole. Definitive treatment, as in other infections, is based on the stool culture and sensitivity results. Turning now to Clostridium difficile infection. The diagnosis is confirmed when C. diff toxin is positive or a molecular test is positive on stool from a patient with compatible symptoms. The first treatment is always to stop all precipitating antibiotics whenever this is possible, and then assess the patients for signs of moderate or severe disease. There are different scoring systems in the literature. One suggestion is that moderate to severe disease occurs in patients with a cell count greater than 15, deteriorating renal function, or clinical signs of colitis. If the patient does not have moderate to severe disease, they should be treated with metronidazole orally for 10 days. You should then ask if there's improvement after 5 to 7 days. If yes, then the course should be completed, but if not, you should treat them as if they have moderate to severe disease. If they have moderate to severe disease to begin with, then the appropriate treatment is vancomycin 125 mg orally. Note that higher doses of vancomycin have not been shown to be effective and should not be used. If there's improvement after 5 to 7 days, then you should complete the course, but if not, you should add intravenous metronidazole to the vancomycin and consult your surgical colleagues, as the patient may need a colectomy. In summary, the vast majority of episodes of acute diarrhea do not require antibiotics. it's important to take a thorough history in patients with acute diarrhoea. Moderate to severe cases require investigation and may require hospitalization. Empiric antibiotics should only be given if diarrhoea is severe or there is blood mixed in with the stool. Clostridium difficile should be considered if there is prior hospitalization or prior antibiotics. And empiric therapy for C. diff depends on the severity of the presentation.